Welcome to the other side of medicine, a trusted source for education, not medication, for 35 years. In every episode of the other side of medicine, we deliver health information your doctor won't tell you about. My guests are the nation's leading health experts in science-based natural medicine, physicians, authors, researchers, and clinicians. We believe natural medicine should be first, drugs and surgery last, and so we promise to deliver you the next generation of health information built on three principles: common sense, science, and cooperation with nature. Well, good evening, everyone, and welcome to the other side of medicine. I am Dr. Krystosik, and we are excited about tonight's episode. We have a special guest in the studio with us. He is a colleague and former classmate of mine from Chiropractic College, and he is the president of the Motion Palpation Institute. And when I was in chiropractic school, I was really impressed with the motion palpation philosophy and the approach to chiropractic. And I think tonight you will see that this is a scientific approach to chiropractic that makes a lot of sense, that can be communicated to any healthcare professional, whether it's a medical doctor, a nurse practitioner, a naturopathic doctor, functional medicine practitioner, a lay person that knows nothing about chiropractic could completely understand in a very simplistic fashion what motion palpation is and how it can help them to get out of pain, whether it's in the back and the neck, or whether it's in any joint in the body. Motion palpation has a system, a science-based system, an evidence-based system that works. And tonight, again, we're privileged to have Dr. Mark King, a chiropractic physician that's located in Cincinnati, Ohio. And I'd like to introduce him. Welcome to the other side of medicine, Dr. King.
I'm excited to be here.
Good. So could you give us some background about, first of all, your background and experience and your educational background, and then get into telling us what motion palpation is all about?
Sure. So I started a practice in Cincinnati, Ohio with my wife, who was also a chiropractor, in 1987, February 1987. And then we were in private practice together, just the two of us, for a few years, and we started growing the practice. And I was still attending Motion Palpation Institute classes. And then eventually I became one of the instructors in January of 1994. And my first class was in Minneapolis, Minnesota. So that's an interesting place to go in January. But anyway, the Motion Palpation Institute was started by Dr. Len Fay in 1981. So it's a very old company. He was a chiropractor who really wanted to attack the left side of the brain, so to speak, the science side of the brain, because some chiropractors at that point were a little frustrated that we were maybe a little too philosophical. We didn't have enough science behind what we were doing. And once you start digging into the science, what we do makes a lot of sense. It's based on human physiology, neurology, the basics of clinical biomechanics, and then you throw in functional nutrition, and you kind of start to see where we're going with that. But the Motion Palpation Institute was really focused on developing these great palpators and adjusters who became great manual care clinicians. And then we wanted to integrate the other things. For example, if you were really good at soft tissue, you wanted to add that into your toolbox, if you will. Or if you were very interested in rehabilitation or functional medicine, whatever the area might be, it was a great foundation for you to get great at and then add to that from there. So I started teaching in 94. Then in 2001, I became the president of the Motion Palpation Institute. And I've been the president ever since. It's 2025 now, almost 2026. And I've been the president for coming up on 25 years. And it's been a wonderful ride, because for me, it's been great to combine my clinical practice with the kind of academic side of teaching. So I just love that combination, because I'm always learning, always getting better at my craft, and I'm always around other smart people. So I just have really enjoyed this ride.
Great. Well, that's a really good introduction, but I would like to get into the biomechanical aspect of motion palpation right now. We can talk about the physiology, integrate that as well, and the neurology, of course. But let's talk about the biomechanical evaluation of a person who has an injury, let's say, a person who has back pain, a person who is experiencing headaches, a person who has problems that can be corrected through chiropractic care with the biomechanics. Could you kind of explain for our listening audience? Again, we're dealing with people who could be professionals here today, but we could also be dealing with a lot of people who are lay people who don't know anything about chiropractic care, or maybe know something that they've had some experience themselves. But I think they'll find that motion palpation is quite different, perhaps, from what they've experienced in what they have experienced going to another chiropractor that practices some other particular technique.
So a big part of this is, let's say it's a new patient. Let's make it kind of start from there. You have to do that good, thorough history. Because we're immediately screening out to make sure they're in the right office, right? They come into the office. We want to start the process of making sure they're a fit for this office, or are we supposed to just be a great doctor and refer them to someone who's better suited to help that patient? So we do a good history, start getting an idea, and then we go into our exam. And our examination includes orthopedic neurologic exam, but we also include functional screens, meaning we watch how they move. A patient walks down the hall. How do they move? How do they squat? We have tests, which lay people wouldn't know, but a quadruped rock, we look at that, and we look at a 6-inch step down. Various, just take them as functional screens. Again, how do they move? Are they strong here? Are they weak there? So we do some testing of strength and flexibility. And our motion palpation exam is more specific to the joints. Are the joints able to move in three planes of motion? And we're going to check that as part of our exam routinely. So it's very comprehensive. So we always try and categorize these patients. One category is, let's call it bad stuff, meaning let's say they have an infection or some disease that we're not geared up to, we're not the best person to treat that. Okay, we get them to the appropriate person. Then we're looking for a lack of mobility. Are they too stiff, too tight, too locked up? Movement is life, so they have to be able to move. And so it's a functional evaluation, not just structural. Then the next thing, we're going to check for stability. Do they move too much, meaning it's unstable and not able to stabilize the area? So visualize somebody bending over to pick up a 25-pound box. Are they mobile enough to get down to it? And then are they stable enough to pick it up without hurting themselves? Then we have the category of biochemistry, meaning what's their nutritional status? And different people go into that in various degrees of depth. And then we kind of have that, call it the other, which maybe includes things like sleep, includes things like your work posture. But the motion palpation part is joint testing the joint for movement. Does it have a springiness to the joints? Because when it does not, if that area becomes locked, other areas have to compensate, and the whole system is thrown out of balance.
Okay, so let's talk about, again, there is, I think, a distinct difference in the motion palpation evaluation of the joints, with the chiropractic community in general. There's a lot of different techniques, diagnostic techniques that people use. Some of them, you often will scratch your head even. And if you would try to use that particular diagnostic technique in front of, let's say, a medical doctor or a nurse practitioner or somebody like a physical therapist or somebody that's in the scientific field, an osteopathic doctor, whatever, they would look at that diagnostic technique and they would just scratch their head again. What is the evaluation of the joints, and how is it different with motion palpation? How does it distinct is what I'm asking here.
So if someone were to watch what I do on a routine basis, because we've certainly had a ton of medical students and chiropractic students, physical therapy students observe, but when they do observe what we do, it instantly makes sense. does the joint have springiness to it? So it's a little silly, but if you think about pushing on a 2x4, that's too stiff, versus a block of cheese, that has some give to it. So we're feeling for that springiness because the joint has to be able to move in the various planes. Otherwise, the muscles that are attached to that joint aren't going to work properly. You're going to get aberrant information to your central nervous system and to your brain. So then the nociceptors, the bad nerves, if you will, are going to be stimulated with this lack of movement. And then we try and restore that balance when we move on to our adjustment. So the science behind it is just the movement. The joints need to move in their various ranges of motion. And if they can't, then the balance is thrown off. I think I'm answering your question.
Yeah, in general you are, but do you happen to have a spine there to be able?
Oh, I'm home now. I don't have anything here.
Okay.
But
So,
what I show to patients a lot of times, Doc, is I'll have them, this ulnomeniscal triquetral joint, I'll have them feel how much that moves, extend their fingers, and then it doesn't move at all because it tightens up. That gives them an idea of what I'm trying to feel when I'm palpating their joints. I'm trying to feel for that movement versus that lack of movement. Right. It's really very simple, and it's hard to learn how to do it, but the concept is very simple. But because movement is life, it makes sense to everyone who looks into it.
Yep. Yeah, there's some, again, first of all, it all starts with a scan, right? A general.
We do a seated scan to start a routine visit.
Talk about the scan of the spinal column and how that's approached and how that's done with motion palpation.
So what we're doing with our scan, we sit behind the patient, and in my office, they're sitting on what's called a Gonstead chair, and I'm sitting on a medical stool right behind them. And I push on the joint on the spine as I go up from the chair all the way up to basically their hair, all the way up.
So you're using your knuckles, your hand and your knuckles, pushing on the spine itself, yes, starting from the very lowest part of the spine. Yeah.
Yes. And you want to get a nice fluid motion going. And what I'm looking for is I'm looking for areas that feel a little tight, because then I'm going to go in and do what we call a localization. I'm going to do a more intense, a more specific analysis.
So as you scan the spine as a whole, as you're moving up the spine and you're scanning the spine all the way up, and then you get to the neck. Okay, you then, what about the pelvis? How do you scan for the pelvis?
The pelvis is here, and I'm pushing PSIS, so upper part of the pelvis, sacrum, or people call it the tailbone. The other side, the lower one, and then I turn up and go all the way up the spine. Then when I get to the cervical spine, my hand is more like this, and I'm keeping their head relatively neutral and feel going up into their cervical spine. That's the technique.
Yeah, and you're looking and you're trying to find the springiness,
yes,
in each specific joint.
The springiness is the right word, yes.
And then you're looking at on both sides of the spine, because you could have one side that maybe is a little bit springier than the other side.
Absolutely.
When you find a block, when you find that resistance, when it feels, it's kind of like you said, it's the difference between going and feeling a 2x4, pushing your knuckles into that 2x4, and you're going to find a block, as opposed to pushing into that soft cheese. You're going to find that springiness.
Exactly. And then that tells you, okay, I need to examine this further.
Okay, yeah. So then you make note of those areas that have those blocks. And so you may find, maybe 4 or 5 really major blocks, right?
Yes. So then you just go in and what you're looking for next is what we call the major fixation, the primary fixation. And we want to go and localize those areas and find out which one is essentially the most fixated, or the most important that we start to work on.
Mm-hmm. Yep. So that general scan is very, very important, because it gives you the locality of the areas that are blocked. Now, what significance to those areas that are blocked? When they're blocked, what could happen by that individual? What could happen to their body as you know, as far as pain syndromes, as far as inflammation, et cetera, et cetera? What could happen if there's blocks there?
Okay, so an easy example is, let's say if everyone knows what the sacroiliac joint is, down by your hips, your pelvis. Technically, your hips are different than your sacroiliac joint, but down by your the bottom of your back. Let's say the right side is restricted, is locked up. Well, what's going to happen? Well, the areas above and below that are going to try and move more to compensate. So then those are the areas that are often painful because they're overworking and they get irritated. This is not every time, but this is a common occurrence. So I keep using the word balance, but that's what happens if I can adjust that area and unlock that area that's too stiff, in this case, the right sacroiliac joint, then they can move more evenly and they will be much less likely to have pain because the pain will be driven by too much movement or too little movement. Again, they have to have the right neurologic input or pain is the result.
Yeah. So if you find, let's say, in the lower spine, and let's say it's in the pelvis, and that sacroiliac joint, everybody knows where that's at in the low back. If there is on one side, let's say there's a block, there's another evaluation that's done as part of the scan with that sacroiliac joint, isn't there?
Well, there's several. Different people have different ways to evaluate this. Some people will put them on their side and check it with them sidelines. Some people will do the old Gillet test. Some people will do it, examine.
Let's talk about the Gillet test. One step at a time.
Okay. The Gillet test is a test that we used to do when the patient would stand in front of you and put your hands on their sacroiliac, or landmarks around the sacroiliac joint, and have them lift legs to see where the movement is or is not working properly.
Okay, now that's what I do in my evaluation. Okay, and so that's what I learned in chiropractic school. I learned from you and the other people of the club, the Motion Palpation Club. That's what I've been using for years. Am I missing something? Should I be upgrading my evaluation?
Well, you're always upgrading your evaluation. You do functional medicine. I know you're constantly studying, but there's always, well, the thing is that the Gillet test is a movement analysis. And I like joint play. So I like to take the joint to end range and spring the joint at the end range. And I find that more precise for me. And typically we teach more the joint play and the sacroiliac joint, either sideline or seated. But a lot of people still do the Gillet test.
Okay, let's talk about who is Dr. Gillet.
Okay, so he was he's from Brussels, Belgium, essentially. He was a Belgian chiropractor. So the way it worked in the United States, there's this brilliant chiropractor named Clarence Gonstead, and he was in Wisconsin, and he was an engineer by trade who became a chiropractor. And so he looked at things very structurally. He took x-rays and drew lines on the x-rays like an engineer would do, right? Dr. Gillet was in Belgium, and he was not allowed to take x-rays. So he used palpation. So he felt for movement because at that point, this is, say, the 40s and 50s, 1940s, 1950s, 1960s. He wasn't allowed to take an x-ray, so he would simply feel the joints. And he developed this motion palpation analysis. And it eventually, chiropractors in the U.S., particularly Dr. Fay, studied under him and then brought that approach to the United States and Canada. And now it's taught all over the world. I was just in Veracruz, Mexico, teaching the Mexican chiropractic students down there. I'm going to St. Louis in a week. Then I'm going to go to Stockholm in Sweden and teach there. So it's all over. It's everywhere now. And it just makes so much sense to people because, again, movement is, I keep saying movement is life. So it's natural to want to have normal movement in these areas.
It's actually taught in almost all the chiropractic colleges now as well. Yes.
Internationally, definitely. There's still some schools in the States that are kind of, I would describe them as stuck in that structural model. But it's not that they're bad schools. They just haven't taken on this movement, motion palpation analysis approach completely yet. Some schools have.
Yeah. It's really interesting. We're talking about the chiropractic approach called motion palpation here tonight. And we're talking about evaluating the spine for movement, for motion, for a springy feel to it. So if you just joined us, we're talking with Dr. Mark King, who's a chiropractor in Cincinnati, Ohio, who's the president of the Motion Palpation Institute and of the Motion Palpation Foundational Approach to Chiropractic. And we're talking right now about specifically the sacroiliac joint. We're talking about that part of the spine. And again, Dr. King, when I evaluate that SI joint, when I'm evaluating it, I'm looking at, again, putting my thumb on the upper part of the joint and the lower part, and I'm looking to see if the patient lifts up their leg, bends their knee, if there is a movement of my thumb dropping down. And I look at it on both sides. If it's not moving on one side, then I know that I have to create motion because it's stuck in that. Could you talk a little bit more about in detail? Or maybe you're going to give it a little more eloquent twist on it than what I just did.
Well, you did a great job of explaining what the Gillet test is. We don't do that as much now. The instructors at MPI, like I say, tend to want to go in and spring the joint more specifically. I shouldn't say it because yours is specific. What I mean is more directly on the joint with a joint plate. So the difference is movement analysis is watching or feeling the movement, the range of motion. Joint plate is going just a little past that, just a little bit past that, and then springing the joint at the end. And there's a lot of different ways to analyze this. And we all get our favorites.
Dr. King, could you go ahead and you have the option to present there, don't you, on the format?
To show something on the screen here?
Say, if you can open up a Google image of the SI joint, since we don't have a spine here to be able to show people, I would just like be able to. Do you see that option to present?
I'm looking.
Present. There it is. Okay. Okay, you can go ahead and I think I just gave it to you right there.
In slides and PDF?
Yeah, if you had something to show, maybe just a graphic. Can you open that up?
Do I have a picture of this? Yeah, I mean,
Yeah, show a picture of the SI joint, and I'll again let people know that can you do that right now?
Well, it'll take me a minute, but yeah, I certainly can do it.
While you're doing that, I'll just again explain to people what we're talking about, and then maybe give them a little bit of a better understanding. Again, we're talking about a particular approach to chiropractic evaluation, an approach that makes a lot of sense, not only to the patient, but it could make sense to any practitioner, whether it's a medical doctor, a physical therapist, another chiropractor, a layperson. They could really appreciate and understand, because this particular approach, this diagnostic approach, is looking at the motion of the joints in the spine and evaluating each specific segment of the spine. And we're finding blocks that are areas that are not moving properly. And when we find those areas that are not moving, as a chiropractic physician, we want to create motion in there. And as Dr. King said, if one area is not moving properly, then in that area that's above it or below it, it's going to have to move in excess. And when it does that, it can irritate the nerves in there and can cause pain. When you cause irritation on the nerves, you're going to get inflammation. You're going to possibly get some what we call paresthesias, or some abnormal sensations, maybe some pain traveling down the leg or tingling traveling down the leg, because the area that's blocked, that's not moving, may be triggering too much motion above it or below it, and then causing irritation and inflammation on the nerve. Dr. King, can you actually share the picture with us?
It's processing, so I'm
Oh, that's okay. Yeah. So once again, this is an evaluation of the spine which will again give us as a chiropractor to be able to focus in on the areas that are not moving enough. Now, you could have an area that's blocked that could actually be pressing on a nerve as well. That itself may happen as well. It's your job to figure out as a chiropractor where that abnormal sensation, that pain syndrome, that sensation that may be traveling down your leg, which nerve is involved. And that's where we get more specific.
And actually, if you're, focused on this palpation, you find the areas that move not enough, but you also find the areas that move too much. So you can find either extreme, and you can find what areas are normal. And then obviously the areas that are normal, you leave them alone. The areas that don't move enough, you're going to adjust. And the areas that move too much, that's where your rehab is going to kick in. Mm-hmm. So that's what I was saying before about, rule out the bad stuff, mobility, stability, biochemistry. If you move on to the biochemistry, are they responding to, say they take a lot of over-the-counter medication, anti-inflammatories, they're inflamed. So now we say, okay, now we need to address the nutritional component because they're inflamed. So Doc, when I have this, this came up here, do I click on this? I want to show these.
You click on add to stage.
What's that?
Just
there it is.
There you go.
I just need to be able to click forward here.
Yeah, that's fine. Yeah, show us the what we're talking right now is the sacroiliac joint, and the sacroiliac joint has 4 joints specifically, 2 on each side, and Dr. King is looking for a representation of showing that joint right now so that we can really understand how these joints are evaluated for motion. And if there's a block, if they're not moving properly, then we're going to go ahead and create some motion there by a chiropractic adjustment. And that's a gentle thrust into the spine. It doesn't have to be, a violent thrust. It just has to be speed.
So this is a picture of a couple different ways to analyze it. This is not the Gillet test, but this is you can see this first one here, the patient's lying on their back. This is their lying on their stomach, and this is lying on their side. There's just different ways to feel the movement that the joint is doing as you compress the joint to feel whether it moves. And these are just some of the examples of the adjustments that we do for those areas that are locked. And then that's kind of an outline of how we think from a flow chart kind of standpoint. But you can see here what this is just a movement analysis. This would be most similar to what you're doing. This is a combination of a movement analysis and joint play. This first one here with the patient on their back, he's pushing down here and feeling with his right hand to feel that joint move or not move. And then this one is more similar here. This lower right one is more similar to what you're describing with the Gillet test. The clinician's moving the leg up and down and feeling the joint movement. That's a movement analysis. So that's a modification of the Gillet test, but on the side.
Yeah, I really like to use that Gillet method, Dr. King, because if, let's say, a husband and a wife comes into the office, and let's say the wife is in pain, or vice versa, the husband's in pain, I could actually demonstrate to the husband or the wife, I can actually put my thumbs on the upper joint or the lower joint. Do you have a picture of the SI joint there, the anatomy of it?
I have to go to another one, but I can eventually find it.
My files are huge. Open up a Google illustration image of the SI joint, and we'll just kind of talk a little bit about that.
And how do I get rid of this one?
Oh, gotcha. You can do that. Unless you don't want to, you can minimize it and open up another screen. But here's the point, folks. And then what Dr. King, when I'm sharing, what I like to do is I'll have the husband or the wife, let's say the husband's in pain and he's got a low back pain. Well, I'll have them stand up, and I do it standing. I'll have them stand up, and I'll put my thumbs on the upper joint, and I'll have the husband lift the right leg, and I'll demonstrate how my thumb drops down when they bend their knee and lift their leg and bend their knee. And then I'll do it on the left side, and they'll see how it moves or if it doesn't move. And then I actually sometimes will even have the husband or the wife put their thumb on, and they can see their thumb drop down when the person lifts and bends their knee. They can actually see the difference. They can actually say, "Oh, now I get it. It's not moving," or it's stuck. And so they say, and the light turns on for them. And I say, "Okay, I'm going to go ahead and adjust it." And then after I'm done, I'll actually show them how it moves. And they're really surprised. They really see the difference and they understand.
Well, and that's educational. The patients, love that when they can kind of see, feel, understand what's going on with that.
I think it's important because it's their body and they need to take a more proactive role in understanding how the body works in a simplistic fashion. We're not wanting to become chiropractors. We just want them to see in a simplistic fashion how the joints move, or if they're not moving, how they should be corrected with chiropractic manipulation. And we have to help them understand that it's a process. When we put that joint back into motion after we adjust it, what's going to happen, the muscles that are surrounding that, especially in the lower back and in the lumbar and in the sacroiliac joint, those muscles are really big. And so they may be tight, and so they may want to pull it back out of alignment again. So that's why they have to get several treatments, right?
Exactly. There's a principle called the SAID principle, SAID, which stands for specific adaptation to an imposed demand. In other words, if you want to run a marathon, you don't wake up one day and go run a marathon. You run a mile one day and then you run 2 miles the next day. I know it's more complicated than that, but you get the point. You work your way up. You get used to the demand of running long distances. And we want to retrain the body to what normal is. And sometimes the body's a little resistant to that at first, and it needs some time to adapt. A specific adaptation to this imposed demand is the adjustment. And then we can kind of groove that new, more normal pattern. And that's part of healing.
Yeah. So again, we're talking about the areas that are not moving enough. And again, if it's not moving, then we're going to create motion with a chiropractic adjustment. And it doesn't have to be a high force. It could just a very quick movement, which is speed. You can move an object with, a lot of speed, or you can move a lot of force. We want to do it with more speed than force, correct?
Yeah, we always say technique, and then speed, and then power. Power is way down at the bottom.
Mm-hmm. Yeah.
Okay, I'm trying to share, cancel that. Hold on, I'm trying to bring this thing up now.
So once again, when that joint gets inflamed, whether it's moving too much or not enough, when it gets inflamed, there's going to be consequences. There's going to be pain. There could be some what we call neuropathy, which is abnormal sensations traveling down the leg, or it could go up from the neck up into the brain. Wherever that nerve travels to, it can send messages that are abnormal, and then people are going to have these different sensations of pain, or what we call paresthesias, abnormal symptom, maybe tingling or numbness, or things like maybe some worms crawling on your skin. It could be any number of different things that can happen, but it's because there's inflammation on the nerve. And what we're doing with the chiropractic is creating, again, that release of that tension and that pressure on the nerve so
Right.
that the body can heal itself. That's what the body does on its own.
I want to show you this slide. How do I bring this up again?
Just click on the actual presentation there. Just click on.
There it goes. So that's the guy who was the founder of Motion Palpation Institute.
Yeah. I actually spent about a week with Dr. Fay out in California when he was, I'm not sure if he's still living or not, but
he's living. I was just with him a couple of weeks ago, and he has just retired.
Okay, gotcha. Well, he's a real gentleman.
Okay, so now we're getting into the sacroiliac joints. Sorry that took so long. This is a look at the sacroiliac joint from behind. Can you see this, Doc?
Absolutely. Yep.
So this is showing the dorsal sacral ligament here, and this is looking at the sacroiliac joint from behind. And this is looking at it from the side. These are biomechanical movements in the direction of nutation. It's an anterior nodding, and counter nutation, which is a backwards or posterior nodding. And it shows some of the posture that goes with those. And so I guess you would say this is a sacrotuberous ligament. Shows this down low here at the bottom of this, but this is looking at the sacroiliac joint from behind. There's the sacrum in the center, and this is the ilium. So what you're affecting when you're trying to do a sacroiliac adjustment, you're affecting the joint and these ligaments around that joint.
And those joints in the sacroiliac joint, can you point your cursor on the joints where they are in the SI joints?
Right here it's not a perfect picture of that because it's a little bit of an angle, but it would be, this is the ligament over top of the joint. So it's right underneath this ligament that I'm scrolling over. So it would be right over here.
Yeah, we don't see your cursor. It's okay though. But in any event, the whole idea is if there's in that SI joint, if there's loss of motion, we're going to create a thrust, a quick speed thrust into that joint, and it opens up the joint and creates motion in it, and then it'll help to release the pain or the abnormal sensations.
Exactly.
So again, we're going to check before for the motion, and after we do our adjustment, we do a post evaluation to see if we got motion in the area. And then we give our patients exercises to do to help to release the tension in the muscles, to stretch them so that they will release the pressure on those joints and help to get better motion over time. So like you said, it takes some time. It's not something that happens overnight. Although sometimes we'll give an adjustment and people will say, oh my gosh, I feel so much better, But the bottom line is, if they don't get regular treatment, because that's been there for a while, the muscles will pull things back out again and there'll be a loss of motion and they'll be back to where they were at. And again, if we have that loss of motion, what are the consequences of that loss of motion in those joints over a long period of time?
Well, degeneration over a long period of time, obviously pain first, but the natural consequence of this imbalance in movement, either too much or too little, is progressive degeneration. And they've studied with this where they bolted the spines together of mice and then took the bolts off after 2 weeks, 4 weeks, 8 weeks, 16 weeks, something like that. I can't remember exactly the timing, but very quickly the mice started showing adhesions in the joints when they took from lack of movement. So too much movement leads to degeneration, and not enough movement leads to degeneration.
And when we talk about degeneration, we're talking about arthritis. We're talking about specifically osteoarthritis.
Yes.
And that's when the joints cartilage, the disc, start to shrink. And it's not just by chance that they shrink, correct?
Yeah, the phrase is it's wear and lack of repair. So our body's breaking down and building up cartilage and discs and joints capsules all day. But if you're not repairing very well, you start to degenerate. So it's wear and lack of repair. That's one of the arguments against taking NSAIDs is they slow that repair. So the degeneration actually goes faster if you're taking a lot of NSAIDs, non-steroidal anti-inflammatory drugs, like a ibuprofen or an aspirin or something. If people are taking those on a routine basis, the lack of repair is actually faster because the theory is that it blocks that. We know that people that take those on a regular basis have more arthritis, but they don't completely understand the mechanism. In the end, for me, there are lots of or nutritional supplements you can do that'll help with the inflammation that don't have the degenerative side effects. So
we're talking about when you take these non-steroidal anti-inflammatory drugs, whether they're over the counter like aspirin or ibuprofen, or they're prescriptive medications. Those medications are going to accelerate or speed up the process of degeneration or arthritis. Is that we're talking about, right?
That's what I'm talking about. Yes. And with bone healing, if you have a fracture, for example, we know that NSAIDs slow bone healing, and actually that also slows tendon and ligament healing. So you may have to have some to sleep or whatever people take them for, but you want to try and minimize that from the simple standpoint of you are long-term slowing down your healing.
Yeah. So when people come in and they're been on taking these medications for months or sometimes even years, not only does it accelerate the degeneration in the joints and the disc, it accelerates the damage to the lining of the gut.
For sure.
And that mucus lining or that mucus layer of the gut starts to get eroded. And then we end up with ulcerations, or we end up, maybe it's not severe, but we end up with what's called a leaky gut. And that leaky gut then causes many ramifications, causes so many problems and so many symptoms, and it contributes a big part of so many chronic diseases. Because then what happens is when you have the erosion of the lining of the gut, specifically the small intestines, you end up having toxins and larger size particles of food and protein molecules that get into the bloodstream and trigger inflammation throughout the entire body. So we're complicating these things by masking the symptoms with these non-steroidal anti-inflammatory drugs.
I've had patients over the years say to me, I came in because my stomach hurt so much, meaning I've eaten so much NSAIDs, ibuprofen or whatnot, that my stomach hurts. Now I'm going to have to finally address my real underlying problem, which maybe is their back or their knee or whatever. But they just, is exactly what you're saying. They just tore their stomach up over time.
And it could be anywhere along the digestive tract. It could be, in the stomach. It could be the small intestines, the large intestine. It's not predictable where it's going to happen. Although a lot of people end up with ulcers in the stomach, it could happen again, low levels of inflammation in the small intestine, which is very problematic. As you erode that lining of the gut, you're going to cause multiple problems. So again, short term, it may not be a problem, and it may be okay to use if you're in severe pain or if you've been in a real traumatic injury. You may be okay to take that, although I personally like to use things like, especially in emergency trauma, I like to use homeopathics. They work so well. Years ago, I had a surgery in my mouth, and they had to go back. This is probably, oh my gosh, 30 or 35 years ago. They had to actually pull back some of the gums, and I looked like a chipmunk with so much swelling in my face. And the dentist, the dentist that was the surgeon, when I left the office, he said, I'm going to call you later in the evening to see how you're doing. And he prescribed some codeine for me, and I never took it. And I just took some homeopathic preparations called Trameal, which I really recommend people to have that on hand. And I took Trameal every 15 minutes. As soon as I walked out of his office, I started taking them every 15 minutes. And I took it the whole day. I did it for the every 15 minutes for the first couple hours, and then I did it every hour. But in the meantime, I got a call from the dentist at about 9:00 that evening. He goes, "How you feeling?" I said, "I don't have any pain at all." He goes, "Oh, that's great. That codeine's working really well for you." I said, "No, I didn't take it." And he said, "What?" He couldn't believe that I didn't take it. So Trameal is a homeopathic remedy that works extremely well. And if you're in a severe pain, you need to take it immediately and start taking it every 15 minutes for a couple hours, and you'll see a dramatic difference. Have you ever used that, Dr. King?
Yeah, but I'm so glad you brought that up, because I haven't used it in a long time. But we used to use it, and I guess we went for a while not using it for anything, and I just kind of forgot about it. I go to things like curcumin and ginger and bromelain and those fish oil. I've always kind of gone for those natural anti-inflammatory supplements, and the Trameal is a great idea. I'm glad you brought that up.
Yeah. Well, I use all those things you just mentioned as well, but I have never found anything that works as quick It doesn't, and nothing that comes as close as working as quickly as Tramiel, the tablets, the capsules, the little tiny pills.
Yeah, I know exactly what you're talking about. Sure.
Yeah. So it's pretty amazing. And again, there's so many things that people don't know about. And that's what we as chiropractic physicians, we're always trying to give people options that are safe and not going to damage. They're going to work and cooperate with the body to help to heal itself.
Yeah, that's the key.
Yeah. So okay, let's move away right now from the low back and let's move right up to the neck. And let's talk about how we evaluate the neck. You kind of mentioned that briefly a little earlier, but how do we scan the neck again as chiropractic physicians?
Well,
Motion
stabilize the
palpation.
head and use their hand to scan up. And then we go in and localize for a loss of extension, a loss of lateral flexion, and a loss of rotation. Those are the movements we're checking when we go to localize. So can your head tilt? Can your head rotate? Can you look up and can you look down? And with that, then we check the springiness at the end of that.
And what we're looking at and what we're touching and we're feeling is what's called the facet joints. Could you show a picture of the facet joints?
It will take me a minute, but
okay, I can be talking about it as you're looking for it. Okay, if that's all right.
Okay.
So once again, we're evaluating as chiropractic physicians with motion palpation. It's a diagnostic technique that evaluates the motion in the joints of the spine. And we're talking right now specifically in the neck about the joints and the facets. And those joints glide on each other and they provide motion. And Dr. King said those joints give us the ability to turn our head to the left and turn it to the right and extend our heads backwards and forwards and sideways and back and the other way. And so that's what we're evaluating. We're seeing how the motion is occurring. And if we find a block in those areas, we go ahead and create motion with a chiropractic adjustment. Again, very high velocity, low force, and create a very quick movement of that spine. And it actually releases that fixation or that joint that's stuck. And it takes the pressure off the nerves. And oftentimes people will see quick results. They may have had neck pain or shoulder pain, or they may have had headaches. And sometimes it'll automatically, within just a few seconds after the adjustment, the patient will be absolutely surprised the pain's gone. Now, it doesn't always happen that way, but they'll be surprised. Sometimes it does. So did you find a picture?
No, they're not going to let me have another picture here on this. So.
Oh, okay. All right. No problem.
So I've maxed out my pictures. They're going to let me show.
All right. No problem. Okay. Well, anyways, we're talking about the joints in the neck. Dr. King, explain again to our patients, to people who are not knowledgeable about chiropractic, what we're evaluating. Again, when you talked about the ranges of motion.
So all we're doing in the neck is we're taking them through these ranges. We're taking through normal range, like this is tilting to the side. We call it lateral flexion. And then whatever level you're on, you push and joint play across to test to see if there's that springiness. Push it on the block of cheese like we were talking about earlier. So does it have that springiness? That's lateral flexion. Extension just means we're looking up at the ceiling and we're going forward on the joint to check for a loss of extension. When we find those losses, whatever direction it might be, then we can go in and do our adjustment for those areas where we're lost. And lots of things can happen. There's a lot neurologically going on in the cervical spine, whether it leads to headaches or radiculopathy, meaning a pinched nerve going down from your neck down into your arm, neck pain, tightness, all those things. Those are all possible things with that joint play. And again, it creates that imbalance. And then we find the areas that are not moving enough and adjust those areas.
Yeah, so a real simplistic way to be able to describe what we're doing, if the joint in the neck is not able to give you full rotation to one side, and let's say it stops right there, then what we'll do is we'll put our fingers on that joint, we'll take it, and maybe if it's stuck in, let's say, rotation, we'll rotate the joint all the way to that farthest point. it can't go any farther. And then what we'll do is we'll create a little thrust in there, and it'll open up that joint, and that patient will be able to turn their neck all the way.
Right.
Just by creating that motion. So we again
three things really happen when we do these adjustments. One, it unlocks the joint, is what you're describing. Two, it helps the muscles in the area relax. And three, it stimulates the mechanoreceptors, which are the good nerves. So eventually it can help with pain. So those are the three main things that adjustment does. And those are important. You want to have normal movement. You want the muscles in the area to relax, and you eventually want to have that pain be less. And it's stimulating those good nerves with our adjustment is a good way to do that. There's other ways to stimulate the good nerves, but the adjustment is one fast and effective way to do that.
Now, again, I don't want to belittle any chiropractic technique or diagnostic approach, because all chiropractors get results with our patients when they're skilled and trained properly. They get results, no question about it. And people get well and they get better. But it's been my experience that with motion palpation, that many times people will have experiences where they get better with a doctor. They're getting some treatments with chiropractic. But until we get the evaluation with the motion palpation done properly and then create motion where those blocks are, the patient doesn't get 100% well, or doesn't get that dramatic relief that they're looking for. And I think
what happens, and I talk about this in my lectures all the time, is this idea that when I talk to students or young docs or old docs for that matter, the examination is really key, that history and exam, because then you can categorize, if you will, your patient. I was talking earlier about mobility, stability, biochemistry, and other stuff. If you do a good exam, you can put them, including this motion palpation exam, you'll know what is going to be most effective for them. Now, or at least you think you know. Nothing's 100%, right? But if you do that thorough exam, you figure out what they need, because some of my patients don't need me. They need to go to the physical therapist and do a bunch of rehab. And that's the best thing for them. So that's what we do. We want them to do rehab and get rehabilitate that way. Now, I'm biased. I love the chiropractic part. I love doing palpation. I love doing adjusting, but not everybody fits into my category a lot. And I know you do functional medicine. You know, a lot of your patients are non-responders to manual care. And a lot of it is because their biochemistry is not right. And they really need to see a functional medicine person more than they need to see someone who does manual care, palpation, and adjusting. So you just have to do that good exam. Where do they fit?
Yeah. Well, another thing is, I think when I was in chiropractic school, I learned with the motion palpation, and I learned this from Dr. Fay as well, that the general saying goes is that 80% of people that go to any chiropractor are going to get results. It's those 20% of people who are going to get the really most benefit out of motion palpation. They'll be able to correct those 20% of people who are really difficult patients that are not responding to the other chiropractic evaluations. And can you talk a little bit about that?
Well, and that goes back to the examination again. Are you being thorough in your examination and trying to really figure out what is driving this patient's issues? Because otherwise you're just guessing. So if you don't examine and figure it out, you're just gonna do, hey, I know how to do this, so I'll just do this. Well, one size does not fit all. So you have to, if you want to help those difficult patients, that's when you need to be doing that great exam and figuring that out. And if you say the patient comes in with low back pain, now there's a whole myriad of reasons you can have low back pain, but part of your exam can help you figure out why, and then helps lead you to which area you should be adjusting and which area you should be doing rehab to and which areas you should be leaving alone. So that's what, if you want to improve your results, that's how you're going to do it. But it comes back to that good history and good exam.
Okay. So once again, we're looking at approaching the spine. We're looking at approaching the nervous system. We're looking at approaching the physiology of the body, the whole person, with not only chiropractic adjustments. We're looking at helping to rehab the muscles and the ligaments and the tendons. We're looking at helping to create better nutrition. so that we can help the body in its natural, normal process of healing itself. And we're making sure that the person is drinking enough fluids. They also are doing some exercises to make sure that they're maintaining the motion that we create. So there's a whole complex system that we're using with chiropractic instead of just giving a person a pain pill like the conventional doctors do. Maybe they'll give some physical therapy, which is good. That's really beneficial. But many times the doctors will just rely on those medications and not send them to a physical therapist, or they never send them to a chiropractor because the physical therapist may not have the skills of the chiropractor has. That's been, we've had, 4 years of specific training after our undergraduate degree and all the basic sciences. We have 4 more years. Most people don't realize this, Dr. King, that chiropractors have the same medical education, the same undergraduate prerequisites, and the same pretty much the courses, I would say almost identical to a medical student's courses. But then we get our training with specific, with the manipulation and the rehab, which the medical doctors don't get. They go into their specialty.
Yeah, they get more pharmacology and they get more surgery. We get more manual care and more nutrition. If you talk to the average family practitioner or any medical doctor, they don't have any. They typically have 1 or sometimes 0 nutrition classes. So we get a lot of good nutrition classes in chiropractic school, but then we get a big focus on manual care, and so we don't spend as much time talking about or doing surgeries or talking. We learn about medications, but not to the in depth the way medical physicians do. We are more focused on this manual care, more holistic care approach.
Yeah, we're trying again to find the root cause of the problem,
Right.
Whereas the medicines are just masking the symptoms, and then again complicating problems because those medications will cause acceleration of the degeneration in the spine or any joint in the body. And speaking of which, with motion palpation, we're not limited to the spine. We can evaluate the knee joint, the shoulder joint, the elbows, any joint in the ankles. We can evaluate each one of those joints and be able to find the restrictions and create motion there as well.
Yes, I'm adjusting extremities all day long. So, if someone says they have, again, let's just pick back pain, and you examine their low back, but then let's say they have back pain when they stand or when they walk or when they run. Well, you sure better be checking that lower extremity, the foot, the knee, the hip, and hip problems go hand in hand with low back problems just routinely. And that's well documented. And stiff hips and a weak core. So you need to get those. When I say hips, I mean hips and sacroiliac joints, but you get the point. They go hand in hand. So I very much am a head to toe kind of examination.
Great. Well, Dr. King, where will people be able to find doctors who actually focus heavily on motion palpation diagnostic techniques?
So our website has a referral list. It's called motionpalpation.org. Motion palpation, not palpitation. Palpation means feeling. So we're feeling movement. Motionpalpation.org has a referral list. So if you're looking for somebody in Cincinnati, obviously my name will come up, but a bunch of other docs will too. And what it means is these docs have all taken a bunch of MPI classes. And so we have classes on the spine. We have them on the extremities. We integrate classes with our rehab. We have gait classes, disc. We have the shoulder. We have our adjustathon, where we just have a whole bunch of instructors and a whole bunch of people there in Kansas City every year. So we have a variety of classes. And so that way people can kind of cover go into whatever particular area they are most interested in. Like the class I'm going to in St. Louis next week is on gait.
Is that what?
Gait, G-A-I-T.
Okay, gotcha.
So we talk about movement, running, walking, jogging, movements. How do you adjust those people? How do you evaluate those people? What's the rehab for those people? And so on.
Gotcha. Okay, well, Dr. King, it's been a real pleasure to have you to share with things about the motion palpation techniques, diagnostic techniques, and the approach to be able to help to rehab the spine and be able to give people an option that makes sense. And again, I think we're talking about a way that we can communicate what we're doing to any healthcare provider or any patient that makes common sense because it's based on science. And that's what the other side of medicine is about. That's what this podcast is all about. It's evidence-based natural medicine. And motion palpation fits in like a hand in a glove. It's perfectly evidence-based. And that's why I wanted to have you on tonight as a guest. So thank you so much.
I'm honored to do it. I'm happy to talk about this subject anytime. So I'm
Is there anything you'd like to leave? Is there anything you'd like to leave for our listening audience tonight?
Well, I just think the future is bright for chiropractic in general because a lot of the particularly, well, I'm in the U.S., so obviously in the U.S., a lot of the people in the U.S. are waking up to this conservative approach to healthcare, not just chiropractic, but functional medicine and rehab and physical therapy and acupuncture and so on. Just a lot of great conservative approaches to healthcare. And a lot of people are waking up to the idea that this is where you should start. Yes, you may need to have a surgery at some point, or you may need to take a medication. But can you start with something that's less aggressive at first, something that's more conservative, more holistic, more natural, and see how you do with that? Because you can always get more drastic. Once you've had the surgery, you can't undo that, for example. So, I mean, I see patients every day that have had, for example, low back surgery, a low back fusion, and they're not doing well. And now what do? It's harder for me and it's harder for them because you can't undo it. The good thing about a lot of these conservative approaches is if it doesn't work, you can get more aggressive, meaning more medication or more surgery and so on. But you'd be amazed at how many things can be handled conservatively so that you don't have to go to those more drastic measures.
Once again, Dr. King, thank you for your dedication to chiropractic and the science of motion palpation. Take care.
Thank you, Doc. Great to see you.